Hello, welcome to this presentation by FERNE, the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled The Evaluation of Emergency Department Dizziness Patients, New Concepts. My name is Edward Sloan. I am currently Medical Director of the Physician Assistant Studies Program at Dominican University. I have most recently been an attending physician at Carle Foundation Hospital, and I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. Support for the development of this lecture was provided by EB Medicine. I am currently President and Board Chair of FERNE. The content for this lecture comes in large part by the monograph titled The Timing and Triggers Approach to the Patient with Acute Dizziness by Jonathan Edlow. It was published in Emergency Medicine Practice by EB Medicine, December 2019. Other parts of this educational lecture and the complete lecture are available at the fern.org website or on our YouTube fern.org channel. Also available is the June 2020 podcast, which was presented to participants in 46 countries, as well as a CME option on the EB Medicine website at ebmedicine.net, as well as at the specific website address noted below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. Let's talk about this new approach and explain it as based on what Dr. Edlow has provided to us. Our history, again, is the mnemonic ATTEST, associated symptoms, timing, triggers, examination signs, and confirmatory testing. This, again, is the clinical pathway, and we have circled in yellow the 4 areas that help us. Is there a general medical cause without stroke symptoms or findings? Does there appear to be a severe constant acute vestibular syndrome? And if not, if it's intermittent or episodic, is it triggered and or spontaneous? So there are 3 steps to this ATTEST evaluation and clinical pathway that we do. Is the medical screening exam normal? Is the dizziness now constant and continuous? And if there's intermittent dizziness, is it spontaneous or triggered? Our ATTEST evaluation using this clinical pathway. We first want to know if there's a general medical etiology such as dehydration. If there is and there's no evidence of stroke, then we just treat the medical etiology. We then want to say, is there constant dizziness? Is it sudden, severe, going on for hours? They present to the ED with this constant dizziness, in which case it's an acute vestibular syndrome. And lastly, if it's not constant at the time of presentation, but more often intermittent, is it triggered? In which case it's a triggered episodic vestibular syndrome. Or is it spontaneous? A spontaneous episodic vestibular syndrome. Here again is the pathway. Now we'll go through parts of it specifically. The red rectangle now has highlighted the portion that includes a general medical cause. So, in your electronic medical record, you want to address medical symptoms and whether or not there are stroke signs. In other words, is there a positive general medical symptom or sign that suggests a specific cause such as dehydration? If there is, then you want to point out that there's no evidence of a likely posterior circulation stroke. You would then say there's no vertical or rotational nystagmus. There's no arm dysmetria or clumsiness or cerebellar finding, and no arm weakness. There's no vision, speech, swallowing, or sensory changes. There's no truncal ataxia or gait abnormalities. Therefore, there doesn't appear to be a stroke, specifically posterior stroke, in this dizzy patient. If you can document all of those in the electronic medical record, then you can treat the presumptive medical cause, and you will have established that you considered the more serious posterior stroke diagnosis but did not find it at the time of ED presentation. The next red triangle then addresses the presence of an acute vestibular syndrome. So in the electronic medical record, the thing that you want to do next, if you've demonstrated that there's no apparent general medical cause based on symptoms and signs, you then want to say, is the dizziness constant and persistent? If yes, you've diagnosed an acute vestibular syndrome. If there is not a constant, sudden, severe onset of dizziness that is not currently present in the ED, and instead the dizziness is triggerable, you then have to consider whether it's spontaneous or episodic. If you look at this next slide, in the clinical pathway, we've now put a rectangle around whether or not the dizziness is triggerable. If there's no acute vestibular syndrome diagnosis, and therefore there is episodic dizziness, you want to consider the trigger question. And if it's episodic, you want to ask the simple question, is this intermittent episodic dizziness triggered or spontaneous? If it's triggered by something, rolling around in bed, moving your head, then you would suggest triggered episodic vestibular syndrome or triggered EVS. If no, it's not triggered, but it occurs spontaneously without any precipitant, you would then say it's spontaneous episodic vestibular syndrome or SEVS. Again, we see the pathway that we've gone through all three parts. General medical cause, acute vestibular syndrome. If none of those, it's either spontaneous or triggered episodic vestibular syndrome. So our ATTEST summary and this clinical pathway. General medical etiology with no stroke symptoms, treat the general medical etiology. If it's constant, sudden, severe dizziness, consider an acute vestibular syndrome and make it one of your diagnoses in the electronic medical record. If you've made the diagnosis of acute vestibular syndrome and you've put that in your electronic medical record, you then can consider two specific diagnoses in acute vestibular syndrome. The first is vestibular neuritis / labyrinthitis or posterior circulation stroke. If it's intermittent dizziness, remember it's either triggered or spontaneous. In triggered EVS, it's either BPPV or orthostatic hypotension. And if it's spontaneous EVS, it's vestibular migraine or TIA. And those will sound like some type of spell that happen intermittently, spontaneously, but seem very similar in their presentation or symptomatology. So we have 3 diagnostic strata and 6 main diagnoses. If it's acute vestibular syndrome, it's either vestibular neuritis or labyrinthitis or a posterior stroke. If it's triggered EVS, it's either BPPV or orthostatic hypotension. And if it's spontaneous EVS, it's either a vestibular migraine or a TIA, some type of circulation and ischemic spell of the central nervous system. So, again, our clinical pathways and ATTEST diagnoses. List of 6 diagnoses are as follows. AVS, 2 diagnoses. Triggered EVS, 2 diagnoses. Spontaneous EVS, 2 diagnoses. 3 main diagnostic strata and 6 main diagnoses. I go over this repeatedly because I believe every time that you now see a dizzy patient, you should be able to think that if there isn't some apparent general medical cause and the absence of stroke, you now can boil it down to 3 strata and 2 diagnoses each. And if you have those 6 diagnoses in a dot phrase in your electronic medical record, it should be possible then to pick one of those 6 so that a dizzy patient will either present with acute vestibular syndrome and it's going to be one of 2 diagnoses that follow, or if it is a intermittent dizziness, you will list it as either spontaneous or triggered, and then you will list one of 4 possible diagnoses. So, we'll ask another question. regarding dizziness characteristics. Patients with an acute onset of dizziness that is persistently present and present at the time of examination in the ED have which of the following vestibular syndromes? A, acute vestibular syndrome, B, triggered episodic, C, spontaneous episodic, or D, chronic vestibular. And we know the answer that is constant, severe, present at the time of presentation is A, acute vestibular syndrome, seen here and explained on the next slide. Seen on page 6 of the Timing and Triggers Approach monograph. In conclusion, the ATTEST system for the evaluation of the dizzy patient includes the following: A, associated symptoms, T, timing and triggers, ES, examination signs, and T, confirmatory testing. ATTEST. When evaluating an ED patient with dizziness, please consider the following. Using the ATTEST system for evaluating ED dizzy patients, those patients with acute, severe, continuous symptoms should be considered to have acute vestibular syndrome. Patients who have intermittent symptoms or non-continuous symptoms at the time of evaluation are noted to either have triggered or spontaneous episodes of dizziness and vertigo. Topping the list of diagnoses using the ATTEST system are orthostasis, BPPV or benign paroxysmal positional vertigo, and posterior stroke. BPPV can be diagnosed with the Dix-Hallpike maneuver and can be treated with the Epley maneuver either in the emergency department or in follow-up. It is noted that you should evaluate patients with caution in the setting of the COVID-19 pandemic, as the COVID virus can cause neurological symptoms and/or can complicate those neurological symptoms because of poor PO intake and dehydration, which can cause orthostasis. Electronic medical record templates and dot phrases can help to make the exam process more systematic and easily accomplished using the ATTEST system. When evaluating dizziness patients in the emergency department, the following is recommended. Understand that the dizziness pathologies using the ATTEST system fall into 3 diagnostic strata and basically involve 6 diagnoses and 3 specific treatments for those diagnoses. Also recommended is that you study the Nystagmus findings, significance, and BPPV maneuvers, Hallpike and Epley, online and in the monograph from which this lecture was obtained. Also, create EMR templates and dot phrases to exclude posterior stroke findings in your dizzy patients in the emergency department. Explain the etiology of the dizziness, including the diagnosis and treatment, and provide appropriate referral for patients with dizziness, explaining to them symptoms which should cause them to come back to the emergency department for repeat evaluation. Lastly, utilize caution when evaluating dizziness patients in the emergency department in the setting of COVID-19, as this virus has both neurological complications and symptoms and can cause orthostasis due to decreased PO intake. If you have specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you to go to the fern.org website for more content related to this educational program and other content related to the care of patients who present to the emergency department with acute illness and injury related to neurological emergencies. Thank you for your participation in this FERNE educational program.